Okay.
Okay. Kind of cautious tales and one a really like crazy case. Okay. So this is a 27-year-old man, and the age is important, who came in to outside hospital with kind of abdominal pain and just non-specific, like feverish, some sort of symptoms like that. Then they thought he had acute cholecystitis. They put in what do you call it, cholecystostomy tube, and then he was kind of not getting better, so they rescanned him. Can you see my screen okay?
Yes.
Okay, so this is cholecystostomy tube, it's in a decent position. And at this point, this was read as, gallbladder decompressed and there are liver abscesses. So then, right, so you can see that. And then no lymphadenopathy, this was read as. So then patient was still complaining of abdominal pain, the drainage kind of stopped, but he wasn't feeling all that great. And then this is, he got MR, I think like a few weeks later, like a week later or so. So now you can see the lesions to this, right? So you can see that the lesions have not decreased. If anything, they became more
definitely
more apparent
than a pink tail mass.
All right, so that pink tail mass is actually just a really big,
Splenial.
what do you call it? Splenial. So let's ignore that. But you can see there's a lesion here, which is probably there on CT. It's hard to see. And then you can see, okay, so you can see these lesions, right? Then let's move to, here's our T2. You can see they begin to have targeted appearance, which, is already not great. We have a little bit of ascites. You can see these masses have targeted appearance on MR. Now, certainly abscesses could have targeted appearance, not that they cannot. You can see this one's also restricted in diffusion right there. But this signal is not perfect for abscesses. Although, depending on, on amount of debris, it could. Then here's the post-contrast. You can see early on, there's not much enhancement, right? And then as you progress, there's more enhancements in these things. Let's just extend it to the delays. Here we go. This is a delayed, again, more and more enhancements. So this was read as worsening abscesses despite presence of the stent, of the catheter, and no lymphadenopathy. I want to draw your attention to these things. Pretty enlarged, kind of heterogeneous necrotic nodes. And actually, when you go back and look at the CT, you can see them here as well. So these are really, this is called reactive lymphadenopathy, but you can see how heterogeneous the nodes are. Reactive lymphadenopathy generally is going to be homogeneous and enhancing, similar to the spleen. These are very hypodense and heterogeneous, so this is very suspicious. And then
two questions. Was his colon normal on that CT? And then why does he have splenomegaly? That's also oh wait,
spleen is not that bad. No, his spleen is not that bad. Yeah, he's young. He's 37. I find that sometimes in young people, spleens a little more generous. Anyway, so when you look carefully on MR, you can actually see that there's extra kind of this fuzzy stuff that is also like extra extension. Sorry, I just want to get another. Anyway, so this is a gallbladder cancer with worsening metastases, and this is just a cautionary tale to, I think SAR had like a great talk about, cognitive biases. I forget what with the name for the bias, but, I think framing bias it's called, like when, it's a 37-year-old man with right upper quadrant pain and, kind of like everything fits together for you to think it's acute cholecystitis with abscesses, right? Because he's a man, he's not a woman, right? Women are more commonly affected by gallbladder cancer. He's young, he's way too young for this disease. He has sort of correct presentation. So I guess the initial CT is, understandable, although again, I would caution anybody who sees lymph nodes like this to be very careful about calling them reactive. But this is kind of reasonable, I guess. But once you get to MR, right, you have growing lesions. They have, like, if I didn't tell you anything, right, I didn't tell you his age, his presentation, you probably would start thinking cancer, cancer, cancer. But I think because of this kind of bias, they kept going in the same path. Anyway, but this is past proven to be gallbladder cancer.
Victoria, I think also you it sounds like you don't have access to the original scan before the cholecystostomy too, but I think that,
I don't. This is the only, yeah.
I think that's where we have to like really scrutinize gallbladders well before we put the tube in, and to see if we think there's actual soft tissue thickening going beyond the wall and stuff.
Right. I mean, sometimes abscesses can really be tricky. Like I remember a case where I was like, for sure, I thought it was going to be cancer with liver invasion, and ended up being like a really ugly abscess. So it can be difficult to separate, but when things start falling into place, just be aware of that cognitive bias. So then the next case, because sometimes it's just like randomly picks out. Anyway, so this was also outside study. Let me take out the measurements. Okay, so you can see here, I kind of focused on this one lesion because it was the largest, but there are like a few of these punctate additional stuff. So you can see it's ovoid, right? It's kind of T1 hypo. Looks like has diffusion restriction. Here's T2, right? Kind of moderate signal, not quite as bright as fluid or even as bright as fat. Here's the other ones, right? And you can see them. And this is what they look like on post contrast. So the largest one, like this, like so. Okay. That. And then the delayed looks like so. What do you guys think?
I wanted to say hemangioma, but I think that would be too easy. Patient doesn't have a history of like mucinous adenocea and stuff.
So I actually don't know I don't remember this is an outside study. So he came already with, with a diagnosis, but this is, this I would caution. So all of these lesions were read as consistent with hemangiomas, but I would be very cautious. I mean, I can see why this was kind of, the hemangioma came into place, right? You can sort of see, but it's not you can kind of make a case, maybe this is discontinuous, but when you look later on, they're not really expanding these little areas of enhancement. Maybe.
T2
right?
is
But
pretty
then
bright.
T2 was not quite as bright as necessary one, but look at
Oh,
the
really?
other ones.
Maybe I was looking at the wrong one.
Look,
Okay.
wait a second. Look at the other ones. Right? Look at these. Right? They're not. This is not hemangioma. You agree?
Yeah, none of them are classic, and so they're just like,
None of them are classic.
Yeah.
Right. So then, T2 is kind of not, this is a SFC. You want it to be a little bit bright, at least as bright as fat. Yeah, but okay. I mean, I'm not saying it's a right, but then it gets better. Then we have this thing, right? This thing, right? It's a mesenteric, central mesenteric lesion. Right there, see that? And then there, right there, right? So it's central mesenteric lesion, kind of
Oh, it's like
spiculated,
cystic neuroendocrine. Ugh.
right? And then another thing is that and this is a difficult call prospectively, but this
Right.
TI is enhancing. I
Mm.
think there was a coronal. And here's, I'll show you okay, here we go. Here's the coronal. You can see that this mass is very spiculated, right? And anyway, so TI is going to figure. TI is a difficult call to make. I'm not going to lie. Anyway,
Actually,
so this
Victoria,
was
on that left-hand image, you can see like all the edema too in that loop on the left side image, the axial image.
Yeah.
Which is like good for neuroendocrine also, because even if it's not the primary mass, a lot of times there's edema or of the loop because of the veins being taken out, but also the serotonin that's being secreted in that region. So that loop does look suspicious also for the neuroendocrine.
So whoever read this case, again, this is outside report, saw the mass, and then the way that they put it together like this: central mesenteric mass consistent with sclerosing mesenteritis, and then liver lesions consistent with hemangiomas. So, right, so that's a little bit of issue with these not integrating the case together. And
I
this
think
is
I
the
mean,
notate.
we don't really, sclerosing mesenteritis doesn't look like that. Like it's not a mass lesion.
Well, it can be mass-like, but I think one pitfall in this case is that the T2 signal is so different in the two areas, right?
Right.
Like in the
Right.
mesenteric, it's dark, which is unusual for neuroendocrine, and then in the liver, it's really bright, which neuroendocrine can do, but it doesn't always do. So like they're discordant.
Right. So this is anyway. So this is neuroendocrine. Here's the notate. You can see all these little lesions ended up being positive. So these are all neuroendocrine tumor mets. And here's the mass is positive, and you can see that the TI has, or whatever, one of the loops has the primary. So we see these cases where people call hemangiomas, and I have like a collection at this point, and there's something not right about it, right? Like you can sort of see why they were going into hemangioma realm, but there's something not perfect about it. And I think that, if it's not perfect, at least say, like get a follow-up, or there's something about it that's not classic. Because once you say hemangioma, everybody forgets about it. So I think unless you clearly can say that this is a classic hemangioma, and the same thing I think for FNH, like unless you truly sure that this isn't, something is FNH, at least ask for a follow-up. Again, I think this is at best, this could be called as a sort of atypical hemangioma. The bigger ones, the little ones are surely not, like they don't enhance like hemangioma. Look, this one has sort of like a rim enhancement, and it just kind of becomes less enhanced later on. So doesn't go for hemangioma.
This is a hard case.
Anyway, it is a hard case.
A very hard case. Cystic
I wanna make
neuroendocrine
one more
tumor of the liver is hard.
about the mesenteric mass. Victoria, if you can go down there. Yeah, so this is a really high nodal met. It's going all the way up to the confluence, which is really unfortunate because normally they want to resect the primary tumor in the ileum and the nodal met. But when it goes all the way up like this, it's taking out too many branches for it to be resectable. So this nodal met in this case, like it's really important to describe how much of the mesenteric vasculature is involved and to what level. And if it goes up too high, those are the ones that like basically can't be resected.
I'm not saying this is like a straightforward case, but I think that if things are not falling into perfect thing when we're talking about typically benign lesion, just
Okay, this is a patient with history of endometriosis and prior XLAP, and had a complex history of like TOA, status post drainage, stuff like that, and had a MR. So what do you think? Where's the new?
I am right here. I'm looking
Right.
at it. I am looking at it, you know. Did they do anything to the uterus? There are fibroids. The junctional
Yes.
zone is thickened a lot.
I
I
see a
also don't like
mushroom,
the
like I
look
see a
of the
really long
rectum back
mushroom.
there.
Mushroom, I hear mushroom.
Yeah.
Yeah, really long
Yeah.
one.
Super
Long.
long.
Yeah.
Right there, right?
Yeah,
So
it's
there's
a
this.
pretty long segment of involvement.
So we give both the length because and then we also give the there's DIE everywhere.
Yeah.
And so we our GYN, they want us to mention if it's involving the muscularis propria or if it's just the outer serosa. They want us to give us the circumference because I guess it's like if it's over 50%, then they have to do a segmental resection. They can just scoop it out. And they want us to provide the length of disease because if it's a super long length, then they can't scoop it out. They just they have to do a segmental resection, which is what they did here. And there is DIE everywhere. So there's that's the most significant part. There's like along the pelvic side wall. And I'm showing this case, and there's adenomyosis. You can see these T2 cystic spaces here. But what do you guys think about this thing here?
Yeah, there's like polypoid soft tissue there, right?
Yes,
We should
and
look at
here
the
I'll give you
contrast.
here's your pre.
Yeah.
Okay, there's like endometriotic deposits there, and then here is your subtraction. It's coming.
I would worry about that polypoid
This
soft tissue there.
and then
Yeah.
diffusion. Where's my diffusion? Here's my diffusion. Okay, here.
Malignant degeneration into endometrioid carcinoma.
There's a diffusion. Or sorry, that's the ADC. And here's the diffusion. Right there. So I heard malignant degeneration to clear cell.
I said to endometrioid.
Oh, endometrioid. Okay, so we had a debate about this because like to me it looked benign. But that was raised, right? Like malignancy was raised. And so patient was prepped for the surgery that would be pretty extensive, dipple tumor debulking. And this all came back as benign endometriosis.
Polypoid. Did it come back as polypoid endometriosis?
I don't remember specifically polypoid, but
Okay.
the pathology was just endometriosis. So the teaching point here is that you can have these enhancing things. Like this is part of the history. A patient had a ruptured endometrioma before, and this is all part of that process. And you can have these enhancing things that restrict.
I still think you have to bring up that it could be malignant. Like I have one that looks just like this that was malignancy. So like if you're saying, they can be benign, but you have to bring up malignancy. You know what I mean? Like it's not going to be, I don't know. Are you suggesting that we should just watch these or?
No. I mean, we were very aggressive and the surgery then became complicated by venotomy and like leak and everything. So because we were very aggressive in trying to get a diagnosis like intraoperatively.
Yeah. Can I interject as well?
Yeah, of
we
course.
had a similar situation recently where young lady and had an endometrioma and an enhancing nodule. Same thing, went to surgery, came back as polypoid endometriosis. So I've tried looking up literature to see whether there are any distinct imaging markers where we can say this is benign and this is malignancy, but I haven't found that answer yet. So that's a good research question, because most of the times these are young, and like in this patient, if they have extensive DIE, the risk of complications during surgery are very high as well.
Yeah.
So yeah, that's something that I'm trying to look into, distinguishing, are there any imaging biomarkers where we can tell one from the other, because we've also encountered a similar situation not too long ago.
So I didn't know about polypoid endometriosis. What is that again?
So it's just proliferative. So I used to think polypoid endometriosis is only seen in older women, postmenopausal women, because that is how I had read the entity as, but apparently not. So I don't know how to distinguish that from, malignant nodules on imaging, but the pathology report just especially in that particular case, just came back as polypoid endometriosis. That's it. They don't give us any more details of how to distinguish it by histopath from, malignancy or whatever. That was just the one line diagnosis, polypoid endometriosis. So
Gotcha. Yeah,
whatever
no, our path is
read
just
about-
endometriosis. It didn't say
it
polypoid.
didn't say polypoid.
No.
Yeah. So
I just Googled it and I found a report from Memorial Sloan Kettering in abdominal imaging from last year about polypoid endometriosis. And they're kind of saying the same thing, like they couldn't initially exclude malignancy. And they ended up resecting it. So I'll have to read more about it, but it says it's an uncommon distinct variant of endometriosis.
right.
First described in 1980.
Can you share your screen?
Yeah. But I don't have any conclusions. I'm just going to share the article I found. Can you see my article?
Yes.
Yes.
So
they used to traditionally, describe it in
polypoid
older women.
endometriosis, mimic of malignancy. It's by the Memorial Sloan Kettering group. Theirs was different. It was like really T2 bright and kind of polypoid looking. Restriction, a little bit, I guess. Actually, it was pretty hyper intense, and enhancement. So, and then they just say there are several imaging features that can aid in the narrowing the differential. T2 characteristics that mirror the endometrium, peripheral T2 hypointense rim, lack of diffusion restriction, lack of ancillary features of malignancy. So interesting.
Need to learn more.
Yes. Okay. Victoria, do you want to go?
Sure. I actually opened 2 cases.
Okay. Yes.
All right. This is a patient who came in with hematuria. And then here's axial. No priors. Oh gosh. Sorry, can you pause it for a sec? So I thought this was a really good pickup. So there's this kind of isodense, hyperdense, isodense primarily, finding in the upper posterior calyx right there. And this turned out to be, any guesses as to what it could be? Or what your differential would be?
Urothelial.
Yeah. Yeah. So patient had like hematuria. So this is the MR. As you can see, that filling defect or that density was this. So this was pathology proven invasive urothelial carcinoma. So I mean, I think
excellent pickup on the CT.
wasn't it like
Very
non-con?
very carefully at the non-con CTs.
Yeah. Yeah.
Great pickup, because you can see it in retrospect.
Yes, you can, and it was picked up prospectively.
Nice.
This is a young person, relatively young person, history withheld. It's the first time I've seen this entity in the liver. So you can see just these extensive T2 kind of hyperintense, but you can see that they're sort of following the.
We only see the diffusion.
triad, right?
Oh, maybe you're only showing us
You should be
diffusion.
seeing 2, no?
No, now we see 2.
Oh, I'm so sorry. I didn't realize that it won't show across the 2 margins. Never mind. So you can see here, you can see kind of moderate tissue hyperintensity. You can see that these things kind of sort of follow the course of portal, right? You can see the same thing on T1.
I have a guess.
Okay, go for it.
Plexiform neurofibroma is one. The other is lymphangiomatosis, but
okay. So I don't know what these entities look like. It's not that, but I assume that they, this is a very non-specific finding, right? The first thing he kind of couldn't hold his breath. But you can see that kind of heterogeneous, very non-specific. The only thing that's weird here, right, is that they follow the portal triad, they narrow the thing. So
I'm going to add peribiliary cysts and corolles.
Well, I'm not sure I would put peribiliary cysts here because it's not, again, it's not bright enough. It's it's the what do you call it? The evil gray of tumor that Aarti loves to talk about, right? You can see that how much brighter.
There's something crazy going on in the pancreas too.
Yeah, and you can see it's like really restricted diffusion, and right. Anyway, so this had to be biopsied, right? When in doubt, right? And some of these are not. Some of these are really discrete parenchymal lesions, right? Anyway, so we biopsy this. This is Kaposi. Isn't that crazy?
Yes, actually, Kaposi loves the perivascular distribution.
Yeah,
thought of it.
Isn't that a crazy case?
Sorry, can you? So this is just how come it's not enhancing?
Metastatic. They're just kind of they're not cysts. They're not like, they're hypo-enhancing, but they're not like completely avascular. But
so it's perivascular metastasis?
Yeah. Well, some of these are parenchymal, but a lot of them are just kind of along the vascular structures you can see here.
So no, yeah, it's like growing along the vessels, and actually that's a pretty classic location for Kaposi's. It's kind of the same way in the lungs. You know how you get flame-shaped, like infiltrating lesions. It's the same thing. It likes a perivascular distribution. So in the abdomen, it goes along the portal vessels, and then it goes along the mesenteric, and then also in the groins, you'll see it growing, like soft tissue growing along the groin vessels.
I missed. What is the primary, Victoria? What was the primary?
Kaposi.
Okay. The patient have HIV?
Yeah. Which is, honestly, I haven't seen such extreme case in so long.
Yeah, I showed a couple that were like this in the liver, just like this. So I'm like disappointed I forgot it.
Well, I think this is like a crazy case to be honest.
This is a 33-year-old with pelvic mass. This is, so let me tell you the sequences: T1, fats at T2, T1, and stir. So the finding is obvious. It's just, what do you guys think? Again, T1, fats at T2, T1, and stir.
This is a female. I see a uterus to the side.
Yes, it's a female.
So this is ovarian?
Yes.
A dermoid, but is it, wait. Well, something fat containing. I guess differential would include dermoid. I'm wondering if it could be like a liposarc as well, but I don't know where it's coming from.
Why is it like satting on the stir, but not the fat sat?
Exactly.
Or like parts of it are satting on the fat sat, and the other part isn't. No, I don't know.
Yes.
Anyone
any thoughts? So this actually is not fat. It is actually an endometrioma and path proven. It's bilateral actually. There's one even on this left side. But the teaching point of this is stir sequence can completely suppress signal intensity of endometriotic cyst, and mimic fat. And that's because some of the tissues like hemorrhage, proteinaceous fluid can all get suppressed on stir sequence, just like what fat would. So the point is, if you just have a stir and a T1, you would end up calling this fat and a dermoid. But here, having a fat sat T2 has really helped us, where there's really no suppression. So this is a well-known phenomenon. It was described. One of my residents sent me this article from Eurorad, where they have basically said that this is a mimicker of fat.
Wow. And you only do stir though on here, we only do it on our MSK protocols.
This is an outside study, so I have no idea why they did it, but I thought it was a great case for physics purposes.
It is. Awesome.
Excellent. Excellent.
Thank you. Okay, Anu?
And with history of prostate cancer blastic meds. And he had, failure to thrive indication for outside CT, and they said that patient had more more liver metastasis, more bone metastasis than it was before, which is correct. And everything else they described as normal. So this is subtle, right? You can see kind of sort of something here, right? Very subtle. And this is the prior, and you can see this, patient didn't have anything here. But, this can be easily dismissed as just, fat. The thing is that this study also includes pre. And when you go to the pre, this is a much more convincing that this is a true lesion. And you can see there's another one here. So this is just an interesting example where a non-contrast was more helpful metastases than post-contrast. I think this is right. So anyway, so that was an interesting case.
Nice. It's almost like an MR.
Do you have the coronal?
I do.
So there was the Roscoe Miller Award from SAR last year was looking at like what differentiates, what kind of patterns behavior differentiates us being able to detect metastasis versus not. And so looking at the coronal was one of the differentiating behavior. Like you pick up more mets from the liver on coronal than axial. And then the other interesting finding was the subspecialist picked up more mets than generalist, but certain types of metastasis, like mets along the edges, both generalist and subspecialist missed equally.
Right. I remember. I really like that paper. I think they published it, right?
Yes, it was published in Radiology.
Yeah. I mean, I can see how this is easily dismissed on, without pre-contrast, I think this would be a very tough call. Although I agree, coronals here are much more convincing. But I think here is just a very unusual example where pre-contrast really is helpful.
In this case, the pre-contrast coronal actually has a beam artifact through it, so it's harder to see for me.
But anyway, but I think this is an interesting case for that reason, where it's a tough case, but here the pre-contrast really helps you.
Awesome. Okay, so this is a patient who came in with abdominal pain, and there is a finding around here. Any thoughts?
I mean the mass, but there's like this linear thing that's coming into the middle, like almost like makes it look like it's iatrogenic.
Okay, yeah. So there's this there's a mass here. It's I'll show you so this part actually looked, there's this linear part, but then there's this other linear part, and I'm going to show you what it looked like.
Like maybe some kind of fibrosis that encapsulated that thing, whatever that thing is.
Okay, and then this is what it looked like on the coronal. So this part almost looked like some kind of dystrophic calcification, And then there's that more linear calcification there.
Is it a desmoid?
What'd you say?
Desmoid?
Excellent thought. It was not a desmoid. And I want you to kind of look at this part of the mass. Like, what does it look like if you were to put it in a different part of the body? Like, there's almost some suggestion of fat in it. And the smudgy kind of stuff.
Maybe.
Well, anyway, we didn't get it. And it was biopsied, and this turned out to be a myelolipoma. So interestingly, I looked online, and there is this case report of a myelolipoma that looks just like ours. So similar location, dystrophic calcification alongside it. These are very rare. You wouldn't necessarily think about it prospectively, but now that you've seen this, and also just kind of like this maybe suggestion of fat, that just know that there's such thing as an extra-adrenal myelolipoma. They're rare. Most of them are actually in the presacral region, and they're thought to be due to patients with dysfunctional endocrine issues. But they're case reportable. They're very rare. Nobody really knows why they occur. But anyway, this turned out to be just a myelolipoma.
Okay, great. This patient came with abdominal pain, had diverticulitis, and then showed up again. And the diverticulitis part was better, but the abdomen, this is post-intervention. There was other area of abnormal bowel findings that you see here. It's pretty long segment. There's areas where there's kind of communication, like fistulization between the adjacent loop here, and any differential, and this is causing obstruction of the right collecting system.
Whenever I see fistula, I always think about Crohn's disease.
Okay, so you thought.
That's what I thought.
This is crazy, like, to come after diverticulitis, and it's like small bowel.
Sorry, they're not related.
Okay, maybe some kind of weird infection like actinomycosis.
Lymphoma?
Yes, this was small bowel lymphoma. This is pathology proven, and then got treated, and then went into remission. So just another, face to small bowel lymphoma, right? I mean, I think we're taught that it causes like ectasia, or just like distension of the bowel. I mean, they're not supposed to be obstructive. This patient had obstruction, but that's one of the consideration, and it was called prospectively in DDX, adeno-CA versus lymphoma.
Very cool.
Nice. Okay, Anu.
All right. So this is a youngish person. And as you can see, one kidney is atrophic. This was a chest CT because they came in with pneumonia. And then incidentally, they found this mass, just the upper cuts of the kidney, no contrast. And so they were sent to an MRI to characterize this left renal mass better. So it was a great pickup on this non-contrast chest CT. And here we have, I'm going to run through the T2 coronal first. And you can blurt out your thoughts as we run through this, focusing on the left kidney. There is a transplant kidney in the right lower quadrant. The native kidneys are severely atrophic. At this point, the patient didn't receive contrast, and so this was only a non-contrast MR.
Is it
Sorry,
fatty?
that's the mass. So we're looking at fat set T2, right? Not a haste.
I'm looking at fat set T2 only.
Can you show us a non-fat set T2?
Or
Yes.
stir, sorry.
I'm going to run through additional sequences. So I still have a fat set T2 here. Do not have a non-fat set T2 on this study.
Is it a flavoid?
That's a great thought.
It's like a dark thing.
Exactly.
Wait. Hmm.
This is the pre-contrast T1. I don't have a non-fat sat T2 on this study, but the subsequent study that was performed, I'm going to give you a non-fat sat T2 as well.
That like reminds me of a big flavoid, huge flavoid.
So, you know, there wasn't contrast initially. You're absolutely on the right track, Aarti. And there was discussion of should we biopsy this thing. However, fortunately, we subsequently have contrast, and you know which way I'm going with this. So that's what this is. So this, the ipsilateral artery is hypertrophied, and then you have this large vascular structure, and then venous outflow as well. So it turns out, as you can see, you know, they have chronic renal failure, they have a transplant kidney in the right lower quadrant. So a few years back, they had a biopsy of the native kidney on this side. And so the thought is this is sort of gradually enlarging AV fistula following a biopsy. You know, there's a paper from 2018 which talks about incidence of development of AV fistulae following renal biopsy, and this paper actually talks of native renal biopsy, and it's pretty common. Apparently, the incidence is pretty common, but most of them are silent and they resolve on their own. But something to be aware of. Clearly, this one didn't resolve and has gradually enlarged in size.
Great case, and important to not just biopsy some renal mass without working it up first.
Absolutely, without the complete picture. Okay, so history of Crohn's, long-standing perianal fistula. And I'm going to start off with this axial T2 non-fat sat. So there is this lesion here, which is T2 hyperintense, as you can see, multiseptated. And then let me see, let me bring up the post-contrast right here. So they do have two transsphincteric fistulae on the same side, and the fistulae terminate in this lesion.
Mucinous.
Mucinous, yes. Yep.
This was called an abscess, and that's the teaching point here. This was indeed a mucinous adenocarcinoma, not to be mistaken for an abscess associated with perianal fistulizing disease. You know, so I was trying to teach myself, how can I distinguish and not make that mistake? So if you look at the, I'm going to show you DWIs. This is the diffusion signal here in this lesion, and look at the ADC. There is no diffusion restriction, and traditionally we are always taught to look for restricted diffusion in abscesses, and then the enhancement pattern as well. You know, the septae enhance, but there's no thick rind of enhancement. I pulled up a companion case of an actual perianal abscess just to show what the enhancement pattern should look like. This is an abscess. It's not a large one, but nevertheless, there is some central fluid and thick rind of enhancement in association with that abscess. So if something doesn't look like that, there's no restricted diffusion, there's very bright T2 signal, multiloculated, think of a mucinous adenocarcinoma.
Yeah, and it has more structure to it. Like it has like, you know, enhancing septations and
Yes.
structure. Yeah.
Indeed.
But this is a pitfall.
Yeah, indeed. Go for it.
Okay.
So what is where is the mucinous tumor coming from? What is the primary? Meaning,
So it's developing in a chronic fistula. It's at least in this case, it was at the inferior margin of the fistula itself. And so the chronic turnover and, of the fistula itself, chronicity can predispose to development of malignancy. That's
so it's not the other way around. It is not like the tumor was there and then it fistulized into the anal canal.
No. They have a long-standing history of perianal fistula related to Crohn's.
And this is where the pitfall comes in, is like you have multiple imaging studies showing fistula and then abscesses. So then this slow growing mucinous starts popping up and you just keep
Yeah.
calling it an abscess. I think it's also because a lot of these fistula are from obstructed glands and the cancer arises from glandular tissue. So like, then it creeps out into that perineal area.
Yeah, and it's very often in association with the fistula itself. So,
Thank you.
mhm.
Okay, this is my case. You can see that there's a large pelvic mass. The bladder's here. Prostate is here.
New paragraph.
Seminal vesicles here. What'd you say?
Sarcoma.
Okay, great thought. And we also thought about, for example, like a stump tumor, which we've talked about here, where we get these like large stromal tumors of the prostate. So anyway, here it is. Anything else on your differential? It did seem like it was affiliated with the prostate, but kind of eccentric to it, affiliated with the seminal vesicle. Somebody's chatting in. Oh, Rupa says we had a gist similar to this. Okay, excellent. So we're thinking, is this a sarcoma? Is it a gist? Is it a whatever? So let me just move this for a second while I bring up. Okay. So now, Nelly, this is for you. First of all, what kind of PET scan is this? The pancreas and the liver are hot.
Rotate.
Nope.
PSMA.
No, but closer. So this was an Axumin scan, fluciclovine, which has now been basically replaced by PSMA, and the mass was pretty hot. So this was read as possibly prostate adenocarcinoma. It was resected, and this was a gist, or sorry, it was biopsied, and this was a gist tumor. So what I learned was, one, don't forget about gist, because you know, rectal, so you can see here, it actually has this very broad interface with the sigmoid colon here. Rectal gists are possible, and you can also get, you know, from the sigmoid colon. So just whenever you have a massive tumor in the abdomen, think about a gist tumor. And then the other thing I learned is that a lot of these prostate, you know, these antigen or these FDG markers are not, they can be very sensitive, but they're not necessarily specific. So for example, fluciclovine is an essential amino acid. So it can be picked up by actually a lot of different tumors, including GIST. So don't just jump to the conclusion that this is a prostate cancer. You know, keep the other stuff in your differential. And PSMA is also not totally specific. We had like a splenic hemorrhage that took some up. So, you know, they're not totally specific.
I'm sorry, the gist was arising from where?
From the sigmoid colon, the compressed sigmoid colon.
Oh, gotcha. Okay.
Yeah.
I mean, it looked like it was like coming from the prostate. Like
Well,
there's like this abnormal signal, but maybe that's just incidental.
Yeah, it was basically kind of like, you know, involving the edge of the prostate, but it wasn't really, you know, like if it was truly from the, and by the way, there is such thing as a prostatic gist, so they can arise from the prostate very rarely, but it was kind of just like invading the edge of the prostate over here. The rest of the prostate was like normal.
Gotcha.
Yeah. So when you see a huge one in the pelvis and it's compressing, you know, like just don't forget about gist, because it can definitely rise from the rectum or the colon.